Dear colleagues, in partnership with the Österreichische Gesellschaft für Nephrologie, the Deutsche Gesellschaft für Nephrologie, the Junge Deutsche Gesellschaft für Nephrologie, and the Société Francophone de Nephrologie, Dialyse et Transplantation, Marcus at Home welcomes Professor Fadi Fakhouri in Lausanne, Switzerland, in order to discuss the management of a tricky and rare disease with a tricky name, immune complex membranoproliferative glomerulonephritis, IC-MPGN, and C3 glomerulonephritis, C3GN. Dear Fadi, it's a great pleasure for us to host you for a third time at Marcus at Home. Welcome back.
Thank you so much for this invitation. It's always a pleasure, and indeed it's a very tricky topic.
Dr. Fakhouri is Professor and Head of Service of Nephrology and Hypertension at the Faculty of Biology and Medicine at the University of Lausanne in Switzerland. He has helped define the clinical and pathological features of C3 glomerulonephritis and immune complex membranoproliferative glomerulonephritis, advanced consensus on the classification, and clarified the role of complement dysregulation in their pathogenesis. His work has also shaped current approaches to diagnosis and treatment, including the integration of complement investigations and the evaluation of novel complement-targeted therapies. Professor Fakhouri, we're delighted to have you back here.
Thank you again. I will focus on new therapeutic perspective in this disease, C3G and immune complex MPGN. Here are my disclosures. So, we have to keep in mind that the term C3 glomerulopathy is a rather recent term introduced in nephrology less than 16 years ago. The most important finding and input of this term is to establish complement dysregulation as the main driver of C3 glomerulopathy within the heterogeneous group of MPGNs. So now we know that C3G is driven by accumulation of C3 deposition in the kidney following or resulting from alternative pathway dysregulation. And in some patients, but in not all of them, on top of deposition of complement degradation product, you may have inflammatory changes dependent mainly on C5 activation. The good news is that the C3G is potentially a reversible process. When you restore a normal complement regulation, especially in the alternative pathway, you can remove C3 deposits from the glomerulus and restore a normal architecture of the glomerulus. On the other side, we lived with the notion of MPGN divided into C3G and immune complex or immunoglobulin-related MPGN, due to the deposition not only of C3, but also of immunoglobulin and C3. But as you're going to see on the next slide, it's not very easy to distinguish one from the other. And a lot of clinical and pathological and physiopathological features tend to suggest that C3G and immune complex MPGN are two aspects seen on different times, different periods, of the same initial disease, and response to new therapy tend to confirm this hypothesis. So, for decades, treatments of C3G and immune complex MPGN relied mainly on non-specific treatment, like MMF and corticosteroid, that was helpful in a subset of patients, with, however, a high risk of relapse after MMF discontinuation. The other problem with MMF is that it didn't target the primary driver of the disease, which is alternative pathway dysregulation and C3 degradation product deposition within the glomerulus. And the first inhibitors of complement system, mainly C5 blockers and C5a antagonists, did not provide a miraculous solution or a disease-changing treatment for C3G and immune complex MPGN. These treatments had an effect probably only on the inflammatory changes of the disease, but not on the primary driver, meaning C3 deposition within the glomerulus. That's why we shifted from targeting the terminal pathway of complement to an upstream inhibition targeting the C3 convertase. And with the assumption is that if you inhibit the overactivity of C3 convertase, you're going to reduce C3 activation and thus reduce C3 degradation product deposition within the kidney. And this has been a major shift in our approach to C3G and immune complex MPGN. Initially, we had mainly 3 inhibitors targeting the upstream proximal C3 convertase. Danicopan, that inhibits factor D, more or less an activator of factor B, iptacopan, an oral antagonist of factor B, and pegcetacoplan, which is an inhibitor of C3 and C3b. 3 of them has been tested in prospective trials. Danicopan has been rather disappointing, as it turned out that 1% of residual factor D activity is sufficient to keep the system going and C3 activation going, which means this approach has been a little bit abandoned, or at least is not the most promising approach in C3G and immune complex MPGN. So I'm going to focus today on iptacopan and pegcetacoplan through the recently published trials. So I was one of the authors of one of the trials, but I will keep my promise and be as partial and as objective as possible while presenting this data. The challenge we had when the design of these studies were discussed is how do we assess the effect of complement inhibition in C3G and immune complex MPGN. Of course, we had to rely on proteinuria. We also had to rely on stabilization of eGFR. But I think for the first time in the management of glomerular disease, prospective trials also included pathological changes. Inflammatory changes with the activity score, but also, and most importantly, reduction in C3 staining. And this is a major change in our approach to glomerular disease that, in my point of view, we're going to be translated in other glomerular disease. So let's start with iptacopan, oral drug that targets factor B that has been assessed in a prospective randomized trial comparing iptacopan 200 milligrams twice a day to a placebo. And after 6 months, all patients were switched to iptacopan with a 6 months mandatory kidney biopsy. The patients selected based on usual criteria, adults, but less than 60 to avoid including patients with monoclonal gammopathy, C3G confirmed by kidney biopsy, optimal standard of care including ACE inhibitors, SGLT2 inhibitors, and MMF and corticosteroids. And this study required having low C3 at inclusion. And of course, you had to have a minimal level of proteinuria above 1 gram per gram. Primary endpoint, of course, proteinuria, but as you see, secondary outcomes included eGFR, composite endpoint of proteinuria and eGFR, but also pathological improvement and patient-reported outcomes. Patients included in the study was rather severe, with around 2.5 to 3 grams per gram proteinuria at baseline, despite standard of care, which included optimal doses of ACE inhibitors and antagonists of angiotensin II receptors, but also MMF and corticosteroids. And as you see, more than 2/3 of patients had more than 3 gram proteinuria per day, rather preserved eGFR, and as I already discussed, 47% roughly in both groups already had MMF and corticosteroids. So you have to analyze the data on top of the standard of care. So the results was very good, with a decrease of 30% of proteinuria at 6 months. And when you switch patients from placebo to iptacopan after 6 months, you also see a very nice reduction in proteinuria, maybe a little bit impressive than compared to patients receiving iptacopan from the beginning. Maybe the delay in 6 months explains the delay in 6 months to introduce iptacopan explains in part this small difference. And when you have a combined composite endpoint of proteinuria reduction more than 50% and stable eGFR, a substantial proportion of patients reach this endpoint, whether at 6 months or at 12 months once you have switched patients from placebo to iptacopan. For example, you have 30 to 46% of patients having more than 50% reduction in proteinuria. So when you go to the subgroups analysis in these patients, the effect is less significant, especially if you focus, for example, on patients having more than 3 grams proteinuria per day, or those having already immunosuppression. But we have to keep in mind that this analysis has been done with rather small subgroups, and we have to interpret this data with caution. And eGFR was stable throughout follow-up, and as you see, the iptacopan-treated patient remained stable in terms of eGFR, and in the placebo group, they had a small decrease in the beginning, but at the end, there was no change in eGFR. And when you take the historical slope of eGFR before inclusion in patients treated with iptacopan, you see a nice slowing of the decrease in eGFR and even a small, probably a small increase under treatment. But to be complete and honest, when you have the same historical slope for placebo, as you say here, the placebo also tend to have less profound or less rapid decrease in eGFR, probably due to better compliance to treatment. So what about pathological changes? The historical index total activity score decreased, but it was not clinically significant, statistically significant. And this studies used a rather complex score to quantify C3 deposition, and you had a statistically significant decrease on C3 deposition, but no data about patients who cleared all their C3 deposits. Tolerance was good, as probably expected, but it's better to see it. No major alerts or serious infections in patients, knowing that 40% of them already had MMF and to some extent corticosteroid. So how about Pegcetacoplan in C3G and immune complex MPGN? So same design, 6 months placebo versus Pegcetacoplan, giving twice weekly subcut, and then everybody switched to Pegcetacoplan. Rather the same inclusion criteria, except that you had adolescent and adult, C3G and primary immune complex MPGN, native kidney and transplant recipient, proteinuria more than 1 gram per day, and of course eGFR above 30 milliliters per minute, as in any clinical trial, and stable treatment standard of care, including immunosuppression or antiproteinuric drugs. Endpoints the same as the previous study, proteinuria as a primary and as secondary, eGFR, proteinuria, composite endpoint, and pathological changes. Patients were rather severe, with more than 2.3 to 1.8 gram ratio, UPCR ratio. Median eGFR little bit lower than the iptacopan study, and as you see, 90% of patients had ACE inhibitors or similar, and 75%, 69 in the other group, had immunosuppression. So you are treating patients who fail to respond to standard of care. And we had some data that are missing in the iptacopan about autoantibodies targeting complement and genetic risk factors, namely variants and complement genes. They were not tested routinely in these studies, but we have some data that we can discuss a little bit later. So this is reduction in proteinuria, minus 60% compared to placebo, once again on top of immunosuppression, and 90% of patients receiving ACE inhibitors and 40% associated to SGLT2 inhibitors. A very impressive result in regard of the severity of patients, but also in comparison to other trials with glomerular disease. And this effect in reduction of proteinuria is stable and evident and statistically significant in all tested subgroups, whether you are adolescent or adults, whether you have C3G or immune complex MPGN, whether you are already on immunosuppressive drugs or not, or whether you have less than 3 grams or more than 3 grams proteinuria. And this is the composite, the secondary endpoint. They go in the same direction. But in my point of view, one of the most impressive results is the clearance of all C3 deposits in more than 70% of patients. And as you see, this pathological improvement is seen even in patients with more than 6 grams per gram proteinuria, UPCR, or even in patients having already immunosuppressive regimen at baseline. No major adverse events in this trial, like in iptacopan. And as you see, when you switch the placebo to group 2 pegcetacoplan, you have a nice decrease in proteinuria, -51 compared to 67% in the PEG to PEG group. So how about eGFR? As you see, in the placebo group, you have a decline around -8 milliliter per minute during 6 months, and you have a reversal and even an increase in GFR, and you end up with -4.7 milliliters per minute. In the PEG to PEG group, you have a slowing of the decrease in eGFR with some fluctuation. If you take the point here, it's stable. The point here is a little lower, and should be very important to keep an eye on how eGFR will evolve and what is the progression of eGFR with an extended follow-up. So these are the results, but you have still very many remaining issues. The first one is when you start treatment. Should we keep the 1 gram per gram UPCR as a golden standard threshold? It's a question to be debated. What complement biomarkers could help select a complement inhibitor, and to tell a patient or a clinician, should I use a complement inhibitor and which one? In my point of view, none. Is the clinical response that will help you say which one will be helpful for the patient. How to define a remission of C3G and immune complex MPGN in the era of complement inhibitors? I think that this definition should include pathological improvement, meaning decrease and ideally the clearance of C3 deposits. And this is a trend we're going to see coming, in my point of view, in other glomerular disease, including IgAN. Should antibodies remain a target for treatment? As you know, up to 80% of C3G patients may have C3NF. We don't know in these trials if they respond equally to patients without C3NF, but should we still aim to clear C3NF with B-cell drugs, especially with new B-cell drugs? Why some patients seem not to respond to proximal complement inhibition? We have to admit that some patients do not respond to iptacopan, neither to pegcetacoplan. Do they have truly C3G? Because diagnosis of C3G is not so easy as one may assume. We will see in the coming years. Is there a place for complement inhibitors in monoclonal gammopathy associated C3G? In my point of view, yes, because this association is based on the fact that monoclonal gammopathy induces dysregulation of the alternative pathway, especially in patients who do not have a clear indication on the hematological side for a specific treatment with chemotherapy. I think that these complement inhibitors will be a helpful tool. When to stop treatment? We haven't started yet seeing the effect in real-life data, and real-life data will be very important to see if the data seen in clinical trials will be translated in real life. But in my point of view, we could discuss treatment cessation when you have decreased proteinuria to a plateau and when you have a pathological remission. And it's not clear whether the presence of autoantibodies or complement variants in less than 20% of patients will change in some way the duration of treatment. So, in conclusion, we are living a radical change to our approach to C3G and immune complex MPGN, but we still have to see how in real life those two complement inhibitors behave. And in my point of view, we have to reconsider UPCR as the sole surrogate marker of disease progression. If you decrease proteinuria with ACE inhibitors to below 0.5 gram per gram, is it the same clinical value if you reduce it to the same level using a specific treatment that targets the primary driver of the disease. So we are still have a lot to know and to learn from complement inhibitors in C3G and immune complex MPGN. Thank you for your attention.
Thank you so much, Professor Fakhouri, for this amazing presentation and talking about therapies that we might give to these patients. Maybe going back to the diagnostic workup, because you only mentioned it shortly, what, in your perspective, should be done in these patients? Do you integrate genetic and complement pathway analysis into the diagnostic workup for these diseases?
Thank you for this excellent question that it still remains debated. And I usually joke with Véronique from Bomback, which is a biologist and expert in complement. What is the value of doing all the complement workup? So I'm going to go back to this. But let's start with the diagnosis. Diagnosis is based on pathology and on immunofluorescence. So it's not so easy in some cases to see if C3 is dominant or if its IgA is dominant in a given patient. So, for example, one of the reasons for excluding patients from the 2 clinical trials is a wrong diagnosis. Sometimes the patient were referred for CCG and it turned out to be IgAN, for example. So this is the first one. The second one is what diagnostic workup you should do. We do a lot of diagnostic workup, including C3, C5, soluble C5b9, autoantibodies, and genetic testing. In point of view, today, currently, they do not change anything to the management of these patients. But if you have a C3G or a suspicion of C3G in your kidney biopsy, and you have a low C3, and you have on top of this a C3F, it will reinforce your confidence in having a diagnosis of C3G. This, I would say, would be helpful. But for the clinical management of patients, I don't think today they're going to change a lot. What we may change is that, as in atypical HOS, it may help us decide how long should we treat. If you have a patient with a pathogenic factor H mutation and C3G, probably you will keep treatment longer than a patient who does not have such pathogenic variant. But I'm afraid complement biomarkers have been overplayed and their importance has been emphasized a little bit too much, in my point of view.
Thank you. Maybe you could elaborate on your current treatment algorithm for IC-MPGN and C3GN. How do you select patients for immunosuppression, or do you give complement inhibitors to everyone you treat?
This is a very tough question, but I'm going to try to answer. In my experience, I do not use any more MMF and corticosteroid. So I wait for 1 gram per gram, but one way question whether 0.5 gram per gram is an optimal threshold. This is true for all kidney glomerular disease, but you have to take into account also the price of these drugs because they are very expensive. We are talking science and medical effect, but you have to keep in mind such things. So I don't use immunosuppressive, and I may even be provocative of saying, what is the first-line treatment for glomerular disease? Should it be ACE inhibitors just to decrease proteinuria by a hemodynamic non-specific effect, or should you go directly for clearing C3 deposition, restoring a normal C3 alternative C3 convertase regulation, or even IgAN, stopping IgA deposition? But price is an issue. So let's keep it to 1 gram per gram. In my point of view, I'll go straight forward for complement inhibitors.
Perfect. Thank you so much. And before starting these drugs, we need to consider some points like vaccines. Maybe you can elaborate just shortly on that for people who may not be so common with these complement inhibitors.
First, even with the terminal inhibitors like anti-C5, we didn't have big issues with infectious complications. As you know, even with eculizumab, well, we do vaccination, of course, and we do prophylaxis, but it's not universal truth to do prophylaxis even with terminal inhibitors. For proximal inhibitors, the safety profile seems very nice, especially when you keep in mind that, for example, in the iptacopan 40% of patients already had MMF and corticosteroids. And in the Pegcetacoplan, 70% already had MMF and corticosteroids. So vaccination, Haemophilus, pneumococcus, and of course, against meningitis. And in my practice, I do not give antiprophylaxis to everybody. I would keep it to patients with initial low C3, just to get a normal C3 and then consider stopping. No, I think the safety profile is not the biggest issue. But vaccination against encapsulated bacteria, the three I stated, and discuss antiprophylaxis on a case-by-case basis.
If I may add here, may it be so the clinical trials always run for 1 year and then you have a follow-up period, but as you mentioned, we do not actually know how long to treat these people, and there will be patients who will receive either of the new drugs for years, maybe even decades. So may there arise some safety concerns in the long-term run of which we are not aware right now and which we couldn't catch in the clinical trials?
I agree with you. In the others, let's say about safety in general, you have data in PNH. It's not the same population, but you have higher number of patients already treated for a more extended period of time with no infectious signals. Okay, but yeah, I agree with you. We are messing with a very old preserved system, and proximal C3 convertase is helpful for opsonization, clearance of apoptotic cells, and all the rest. Yeah, one should be cautious, but I think PNH data are rather reassuring because they have hundreds of patients treated with both drugs for an extended period of time. But they are not the same population as C3G and immune complex MPGN patients.
Great, thank you. Maybe talking about remission, you already mentioned what you believe should be considered when talking about complete remission for these patients. My first question would be, what kind of time period are we talking about? Are we talking about 6 months? Are we talking about 12 months? I mean, we know how long the studies were going, but in real life, what is the time period we should consider? And then as a follow-up question, would you do biopsies in all of the patients receiving complement inhibitors to see if the staining goes down?
I'm going to start by the second question. Yes, I will do it. And I think some nephrologists are keen on the idea. And I will do it once you have reached a plateau of proteinuria for at least 3 to 4 months. Because you can decide stopping before you reaching a plateau, the minimum level you can reach of in proteinuria, and then do kidney biopsy, which give us 6 to 9 months. Because as you have seen in both trials, the decrease in proteinuria starts very early, but usually at 6, 8 months, you have gained what you should gain, what you can hope to gain from reducing proteinuria. So yeah, 6 to 9 months, and then do kidney biopsy. In a patient where the deposit did not clear, I would be more reluctant to stop compared to one that has cleared all, in whom all the C3 deposition or immune deposition were cleared during treatment. But once again, we don't know how many we're going to relapse, so we are starting to learn how to use this drug, as we did with eculizumab. As you know, eculizumab and atypical HOS, we start with the assumption that all patients should be treated lifelong, and then we refined our... Now we have finally a treatment, 2 options of treatment for this patient, but it's more trickier than atypical HOS because the endpoint is longer. You have to proteinuria. Atypical HOS, well, the question was settled with 20 patients, even in open label, because you saved patients from dialysis. Now it's going to take longer to see the effect in real life and then decide when to stop or not to stop.
And I have the same question on biopsy, but on the other side of the time schedule. So since we have now 2 drugs that are available, and surely all of us have done biopsies in the last, say, decade, and we have a couple of people who have been diagnosed with C3GN, in whom the biopsy goes back 5 years ago or something. So would you recommend us to rebiopsy these people? Because if I understood it right, in both clinical trials, patients with advanced sclerosis have been excluded, haven't they?
Yes, they have been excluded based on EGFR, but also, as you mentioned very rightly, based on IFTA or fibrosis higher than 50%. This is a very good question. I would do a recent biopsy, or at least have a recent biopsy before starting treatment, just to see what I can expect in terms of reduction of proteinuria. Because if you have already 40% glomerulosclerosis, you can't expect clearing or proteinuria. The second is that in some patients with both drugs, sometimes we see decrease in proteinuria, clearance of deposits, but EGFR is still declining, probably due to nephronic reduction, and you are beyond the turning point from the beginning. Maybe you're gonna save some time, but we don't have data for patients below 30, and real life is gonna tell us, but it's crucial to have a recent baseline biopsy to see what reduction in proteinuria you can expect and to explain a potential further decline in EGFR based on fibrosis initially.
So in people with advanced fibrosis, we should not consider then to
I
start
don't
with this
know.
treatment?
Honestly, I don't know. It's
All right.
like treating non-vasculitis in a patient who has already 20 milliliters per minute. Should you treat her or him or save immunosuppression for renal transplantation? Below 20, my opinion is to save IPTA and PEG for a potential recurrence of kidney transplantation.
And Marcus, one last question from my part, or actually one question with some sub-questions maybe. So again, nomenclature is so difficult. And this is really the GN, which is, I think, most horrifying, not only to the patients, but also to us regular nephrologists who are not really so deep in the field as you are. So if I got it right, this old nomenclature with type 1, type 2, type 3 is fully outdated. Now, in your VALIANT study, you have included people with IC-MPGN, which to my best understanding have not been included in the second study. So this is really specific in your study. And then when we look into KDIGO guidelines, it's indicated that there is idiopathic IC-MPGN, and this should correspond then to primary IC-MPGN as an inclusion criteria in VALIANT. Did I get it right?
Yes,
All right.
but this is a problem. You have the same problem with TMAs, but let's focus on C3G immune complex MPGN. And to do some publicity, we will have a KDIGO meeting next April. And one of the questions would be the nomenclature also of C3G and immune complex MPGN. Because it was based on the assumption that you have alternative pathway dysregulation on one side and classical pathway activation on the other side with immune complex and immunoglobulin. And it turns out, at least in the VALIANT study, that both of them respond equally to alternative pathway inhibition. So, in my point of view, type 1, type 2 to 3, you can forget it. And even if you notice, we don't speak anymore about dense deposits. I told you that C3G respond. Nobody told me, and what about DDD versus non-DDD? Honestly, we'd never proved that they change anything to the prognosis of the disease. And this endless discussion about DDD, non-DDD, C3G versus immune complex MPGN, maybe treatment option and response to treatment will help us solve this nomenclature problem once for all. But I agree with you. It's disturbing for clinicians and for patients. And I was stuck to C3 glomerulopathy because it is easier to pronounce, easier to memorize, and it points out directly to the problem. C3 deposition, you have to clear it.
So it's April 26 or April 27?
6.
So we have to have you back before Christmas. Marcus, sorry.
Yeah, thank you, Fadi. My question goes on the same line. So essentially, maybe referring to what you have shown, I think in the first slides. So C3G and IC-MPGN are, so to say, one spectrum. It's one kind of a disease. It's kind of complement dysregulation. I mean, I refer to our really good pathologist in Vienna. When we made our consensus statements for Austria for the treatment 2-3 years ago, he said he doesn't want to use the term at all, MPGN. So we didn't know what should we then tell about. And so we'll wait for your KDIGO meeting. But the fact is now to the causal relationship. You already mentioned that the classical pathway is activated. Do you know in how many patients you see that? And maybe this is on a subjective note, when I see, for example, C1q, I always say, it's not a good prognostic omen. But you say, yeah, it will also be maybe successful with complement inhibition, and how many patients you have it. And on the line with that, because the patients ask me, where do I have this disease? Could you make some causal inference to classical triggers of this dysregulation?
So thank you for this opportunity to approach this topic, which is one of my favorite topics. So I didn't say that I believe that immune complex MPGN is related to classical pathway activation. I said it was this division was based on the assumption that you have this. But when you look to the data, less than 5% of patients with immune complex MPGN have low C4. One of classical feature of classical pathway activation, when 60 to 80% of these patients have low C3 and normal C4. You take, for example, the percentage of patients having C3NF, which targets the alternative pathway. You have 60% of immune complex MPGN. And you have no clinically relevant autoantibody targeting the classical pathway that has been identified. So you take everything, and even the very rare complement gene variants detected in immune complex MPGN and C3G are in the alternative pathway. So I believe that immunoglobulin deposition is a bystander. And when you repeat biopsy before these complement inhibitors treatments, immunoglobulins, they come and disappear. They come and disappear. C3 was always there. So I think it's a non-specific trapping, but this is one. Do they amplify the deposition of C3, for example? Even this, I'm not quite sure. When you see the impressive result with PEG, regardless of whether it is C3G or immune complex MPGN, and I'm not sure that any clinicians or any pharmaceutical company will be very keen on the idea of testing classical pathway inhibitors in these drugs when you have everything pointing towards alternative pathway. If it turned out, for example, that PEG did not work as nicely in C3G and immune complex MPGN, you would have changed the picture. But you don't have enough arguments telling you it is the classical pathway activated. You don't have variants in the classical pathway genes. And on top of this, inhibiting the C3 convertase, alternative C3 convertase helps a lot in immune complex MPGN. I think it's an old distinction, but it's hard to change because a lot of clinicians and a lot of pathologists do not believe that primary immune complex MPGN exists. They say it's lupus-like. 20 years ago, they told us to check for hepatitis C. Now it's almost disappearing. But still, it's hard to admit. So, in my point of view, we should call all of this C3 glomerulopathy and forget about immune complex MPGN. But this is just a personal opinion.
This would make the world much easier. But did you have patients in your study that had both C3 and C4 decreased in the periphery?
I don't have the figure. In my personal experience, I have a couple of them. They had very slightly decreased C4 because they have a huge decrease in C3.
Okay.
But both of them normalized under treatment.
But like when there's a patient that has both decreased C3 and C4, and in the biopsy you see C3, C1q, and IgM, for example, would you still consider him under the umbrella of C3?
Yes. If C3 staining is 2 pluses more than the others, yes.
Yeah.
Otherwise, it should be, name it. If I think which is important is, would you use in this case alternative pathway inhibitors? In my point of view, yes. The name is, let's leave it to pathologists.
Yeah, and Professor Regele always pointed to this. Yeah, he was really great. Maybe one or two clinical questions. We have the special situation here in Austria that we get one of these drugs for 3 months because of insurance, and then they say, if it works, then we pay it. And then we looked at, of course, at your graphic very closely. Is there sufficient decrease of proteinuria? It's an average. What would you say in this case? You have to wait 4 to 6 months before you say anything else, or?
Honestly, if you don't see any trend at 3 months, it's a not very good sign.
Okay.
But in trials, it started at 1 month, but it's a mean. But very old disease, for example, a patient who had 5, 10 years evolution, who has tried everything possible, and you put him or her on IPTA or PEG, I would wait 3, 4 months to see if you have at least a trend. But
Okay.
if you don't respond in 3, 4 months,
Because it is a variance of what Gunnar asked you, because many patients that we catch now, they already had a biopsy 5, 6, 7 years ago, or even the young ones.
yeah,
How many did you have to exclude from the study when they had more than 40% IFTA?
I don't have the figure, to be honest.
But
I don't
it's,
have the
yeah,
figure. Because they were excluded and they are not in the manuscript, so I don't know.
okay, because they're very young and they don't like to undergo a biopsy. And
I think the adolescent, it was the 6 months biopsy that was not mandatory. At inclusion, it was mandatory, yeah.
okay,
I don't know, I don't have the figure. I don't have the figure.
okay, yeah. So from my part, this was an illumination again. Thank you, Fadi.
Thank you for the invitation and for your very good questions because it helped feed the discussion with very good topics. Thank you. You are helping me a lot to
Thank
finish this presentation.
you.
Thank you for being back on Markers at Home, Professor Fakhouri. You definitely stilled my fear of these diseases. We will be glad to have you back on after the KDIGO
Anytime.
meeting.
Anytime.
It's always great to have you on here. Thank you again.
It's always a pleasure to be with you, honestly.